All right, it's 1:05. We are exactly on time, which feels amazing. So thank you, everyone. I'm Christina Socox. I am the Research Director for Digital Health at the Duke Margolis Center for Health Policy. Just as a reminder, we are giving audio descriptions of what we look like to increase the accessibility of this event. So I am a white woman with brown hair, brown eyes. I'm wearing a pink sweater that is masquerading as a blazer for this event. And I'm very excited about this session, amply amped up by Yogi at the last session, so very nicely. We're going to be hearing from representatives from the Biologics Effectiveness and Safety Systems, also known as BEST. And they're going to be diving a little deeper into the work that they've been conducting over the past year, discussing the enhanced capabilities of the BEST infrastructure to monitor the safety of vaccines, including COVID-19, influenza, mpox, and RSV. They're also going to summarize some of the BEST safety and effectiveness activities over the past year. I love that acronym. Exactly. And the methodological advancements to support the robust development of RWE. We're going to be hearing a combined presentation, so they're going to be tag teaming all along the way, followed by a moderated discussion and also questions from the audience. So don't forget to use that Slido link. If you go to slido.com, you'll see a little place to put in the password, which is basically #Sentinel, and that'll pull you right into the space where you can ask questions. So now I'm going to introduce my panelists, and they're going to jump right into their presentation. So first we have Joanne Gruber, an epidemiologist at the Office of Biostatistics and Pharmacovigilance at the Center for Biologics Evaluation and Research at the US FDA. Then we will have Mao Hu, a policy researcher at Acumen. And then Patricia, a health statistician, also at the Office of Biostatistics and Pharmacovigilance. Thank you. And then finally, Lauren Peatlock, who is an epidemiologist at Optum. So I'm going to go ahead and remove myself from the podium so y'all can get started.
Okay. All right. Thank you. Okay, let's see if you can hear me okay. All right. So good afternoon. My name is Patricia Lloyd, and I am a health statistician within the Center for Biologics Evaluation and Research, or CBER, at the U.S. Food and Drug Administration. I'm here today with a distinguished panel of statisticians and epidemiologists to describe the innovations of the Biologics Effectiveness and Safety, or BEST, initiative toward improved data infrastructure to support safety and effectiveness activities. So we have no conflicting relationships to disclose. The findings and conclusions of this presentation are those of the authors and do not represent the official position of the US FDA, Acumen, or Optum. So over the next hour, you will learn about the BEST initiative. I will start off by giving a brief overview of the BEST initiative, including some recent enhancements that have been made to the infrastructure of the program. Then next, Dr. Joanne Gruber will then provide an overview of the safety surveillance activities during the last year, and will be followed by Mr. Mao Hu, who will give an overview of the safety surveillance activities for the upcoming year. And in addition to safety, it is critical for FDA to understand the effectiveness of vaccines when administered to the US population. And so Dr. Lauren Peatlock will provide an overview of the COVID-19 vaccine effectiveness studies using the BEST system. So I know that you've seen this slide before, but just to kind of recap, the mission of CBER is to ensure that biologic products authorized and approved by FDA are safe and effective. One of CBER's plans for fulfilling this mission is through the CBER Surveillance Program. The overall vision of this program is to create and utilize an active surveillance program or system for monitoring the safety and effectiveness of these products, which includes vaccines, blood component and blood-derived products, human tissues, and cellular products. So through multiple contracts and various partnerships which make up the CBER Surveillance Program, CBER works with a diverse group of epidemiologists, data scientists, and clinical experts to conduct active surveillance studies. There are 3 components of the CBER Surveillance Program, including federal partners such as the Centers for Medicare and Medicaid Services, or CMS, academic partners, and the Biologics Effectiveness and Safety, or BEST, initiative, which include our data partners who provide administrative claims and electronic health records, or EHRs. When it comes to surveillance of biologics, biologics have unique characteristics and their surveillance requires specific capabilities. And some unique characteristics of biologics include the fact that vaccines are administered to healthy populations and children, which means that there is going to be a very low threshold for the risk of adverse events. And so in that vein, to expand and enhance the BEST initiative and to customize its components for the surveillance of biologics, the following components are required. We require an EHR network, which provides access to granular clinical data that are not available in administrative claims data sources, a reduced data lag of about weeks rather than months, which allows for monitoring of newly approved and authorized products, on-demand capabilities or analytic capabilities, where more complex studies can be conducted without the use of prepackaged tools and programs. Next, we also need access to large claims databases. We need an expandable common data model that can be adapted to our surveillance needs, as well as an easier, faster, and affordable access to medical charts for validating exposures and outcomes of interest. So data from administrative health insurance claims and EHRs are rich sources of information, but they're used to inform topics ranging anywhere from public health surveillance to comparative effectiveness research, to identifying patients who may be eligible for inclusion in specific studies or interventions. Data sourced from individual sites, they can be limited in their scope, in their coverage, and in their statistical power. So sharing and pooling these data for multiple sites and sources, however, present additional issues, including administrative, governance, analytic, and patient privacy challenges. So in a distributed data network, there's no central repository of data that exists. Rather, data are maintained by and reside behind the firewalls of each data contributing partner in a network, who then transform their source data into a common data model and permit access to data through multiple uses of a standard query approach. Okay, so the BEST initiative has access to a diverse types of data, including administrative claims data, EHRs, as well as linked EHRs, as you can see in this table. These databases cover millions of individuals, and the data lag ranges anywhere between a few days to a few months. In addition to these data sources that I've just mentioned, we also have enhanced the BEST infrastructure through the inclusion of data from Immunization Information Systems, or IIS, and through development of algorithms for linking pregnant individuals to infants and claims data. So all of the studies that you're going to hear about in the following presentations in this session rely on large administrative claims data, Medicare and commercial claims, which have relatively short data lag and are refreshed frequently to monitor rare events. However, we found that during the COVID-19 vaccine rollout that administration was not completely captured in our health insurance claims data because vaccines were administered in some settings that didn't generate claims, i.e. the mass vaccination campaigns. So when we do not have complete vaccination data, our study subjects may then be misclassified with respect to their vaccination status. And this undercapture, this misclassification of vaccine status will impact our overall study results. So to address this problem, we augmented our surveillance data with data from IIS. Unfortunately, because there's not one single national system for capturing vaccination data with person-level identifiers, we have engaged with state and local IIS. So our team considers IIS to be key partners in the FDA public health mandate to monitor the safety and effectiveness of vaccines. IISs provide critical and crucial vaccine data which will improve the FDA BEST safety and effectiveness surveillance. These data can be used to conduct more robust, accurate safety and effectiveness studies, contribute to regulatory decision-making, and provide input for benefit risk assessment as well as improve public health communication on the safety and effectiveness of vaccines. And our ability to evaluate the safety and effectiveness of biologics in pregnant individuals and infants rests in our ability to identify these populations and link individuals in claims databases. Such a linkage will enable us to identify pregnancy outcomes as well as identify correct gestational ages. So using an algorithm to link pregnant persons to their infants we, in a few different data sources, we did achieve robust linkage rates for the majority of pregnant persons aged 25 through 29 years through ages 45 to 49 years. And so to further work on these activities, some of our next steps include developing and executing processes that will help us compare characteristics of linked versus non-linked mothers and infants, and also to use this linkage for evaluating pregnancy and infant outcomes following exposures to biologics. So next you're going to hear from Dr. Gruber, who's going to talk more, provide more details about the safety surveillance activities that occurred in the previous fiscal year.
Good afternoon. I'm Joanne Gruber. I'm a white female with brown hair and glasses and a black suit. Today I'll be speaking about the safety surveillance activities for fiscal year 2023 and undertaken by the BEST initiative. As mentioned earlier in the sessions today, we did several studies on the safety of COVID-19 vaccines in this past year. Our work focused a lot on the pediatric populations as well as the bivalent booster doses that were administered. We also did other vaccine safety studies that I'll touch on briefly, including studying the safety of vaccines to prevent mpox and influenza vaccines. So we've been monitoring the safety of COVID-19 vaccines in the pediatric population. Initially, our surveillance focused on Pfizer-BioNTech in the populations 5 to 17 years, but with new authorizations that happened in the last year with expanded age groups, we expanded our monitoring. So the design of our study was a signal detection study to look at and do near real-time sequential testing, looking in our data sources that were our claims data sources, CVS Health, Carelon Research, and Optum, with these databases that were linked to the immunization information systems that Dr. Lloyd just mentioned. The study population was health plan members receiving original monovalent doses of the Pfizer-BioNTech or Moderna vaccine for those that were 6 months to 17 years, and Novavax for those 12 to 17 years. Our study period was the earliest authorization date for those vaccines through February or April of 2023. We looked at 21 pre-specified health outcomes, and 15 of these were assessed with our sequential testing. And that was the statistical analysis. We did monthly sequential looks at the data to see if we detected any signals, and we determined if there was a statistical signal when the observed adverse event rates exceeded our expected background rates. So we observed about 8.4 million doses of vaccines administered in our pediatric population. Of the 15 adverse events that were sequentially tested, 13 did not meet the threshold for a statistical signal, and those are shaded in blue. 2 did meet the threshold for a statistical signal, and those are shaded in pink. There was a statistical signal for myocarditis or pericarditis among those 12 to 17 years of age following Pfizer-BioNTech vaccine in all 3 databases. And there was also a signal for seizures or convulsions among children 2 to 4 years of age and following Pfizer-BioNTech vaccine in all 3 databases, and 2 to 5 years of age following Moderna in 2 of the 3 databases. So in conclusion, the signal for myocarditis and pericarditis in children that we detected for children 12 to 17 years is consistent with existing literature. And as was mentioned earlier today, the new signal for seizures or convulsions is being followed up and further evaluated by FDA. And at this time, FDA still believes the known and potential risk of benefits of COVID-19 vaccine outweigh the known and potential risk of COVID-19 infection. In addition, I forgot about our results here, dissemination follow-up. So we did publish our interim results in JAMA Pediatrics in May 2023. We just submitted these final results of our monitoring in October of 2023. They're available via preprint, so you can scan the codes if you would like access to any of these. And as I mentioned, we're doing a follow-up study to evaluate that seizure signal that was detected, and we have a posted protocol online. So in addition to our pediatric monitoring, we also did near real-time monitoring of the bivalent booster doses. So the study design and the data sources were the same with the inclusion now of the Medicare database. Our study population included health plan members over the age of 6 months receiving a bivalent dose of Pfizer-BioNTech or Moderna. And our study period was, again, the earliest approval or authorization through mid-2023. We looked at 18 to 21 health outcomes that were monitored either descriptively or sequentially, and that depended, the number and the type of monitoring depended on the age groups. And again, we did monthly sequential looks at the data to look for early signals, and a statistical signal was observed and declared when we saw adverse event rates that exceeded our expected background rate. So we saw about 13.9 million doses of the bivalent mRNA vaccines. Of the 18 adverse events that were sequentially tested in at least one of the age groups, 16 did not meet the threshold for a statistical signal. Those are shaded in blue. And 2 did meet the threshold for a statistical signal. Those are shaded in pink. There was a statistical signal for anaphylaxis among those 18 to 64 years of age following bivalent Pfizer-BioNTech and Moderna doses in one database. And there was also a statistical signal for myocarditis or pericarditis among those 18 to 35 following bivalent Pfizer-BioNTech in one database. So these signals were consistent with the existing literature for the COVID-19 vaccines and continue to support the safety profile of the mRNA COVID vaccines. So in terms of the dissemination and follow-up for these studies, we are preparing our results to be submitted very shortly. In addition, the FDA Vaccines and Related Biological Products Advisory Committee, or the VRBPAC, is probably more commonly recognized, meeting on January 2023, we reported our interim results of the bivalent booster monitoring with a particular focus on the population over the age of 65. Because there was a signal, as was mentioned earlier, CDC had detected a signal for bivalent Pfizer vaccines in the over 65 population for ischemic stroke. And so we had not seen that in our database, so we were able to report that at the time of the VRBPAC meeting, and we still continue to not see that in our near real-time monitoring. But out of abundance of caution, of course, we wanted to evaluate that safety signal, and we conducted a study, designed and implemented a study to evaluate the stroke risk following COVID-19 mRNA bivalent vaccines that was mentioned earlier today. This is a link to the preprint if you'd like to refer to that. So in addition to these studies, we have completed and have some other ongoing projects related to COVID-19. These include a signal detection study on the safety of the monovalent mRNA booster doses in the adult population, a self-controlled signal evaluation study of the potential adverse events following original monovalent mRNA vaccines in the population over the age of 65, and an ongoing study to look at the risk of adverse events after COVID-19 diagnosis. Finally, we're looking and validating algorithms to identify multi-inflammatory syndrome in children, or MISC, in claims databases. So I spent a lot of time talking about COVID-19. We also have done other work with other vaccines, so I'll touch on those briefly. We monitored 11 adverse events following Jynneos vaccines in adult 18 to 64 years of age using monthly analyses. So Jynneos was the primary vaccine that was used in the recent mpox outbreak to prevent mpox. And so the results of that monitoring will be disseminated shortly. And we also monitored 4 adverse events following seasonal influenza vaccines among the population over the age of 65 with an end-of-season analysis. And we've submitted that, and the preprint for that is available with the QR code. And with that, I'll turn it over to our next speaker, Mr. Mao Hu. We'll be talking about our safety activities for next year. Thank you.
Hello, hope everyone is doing well. Thank you, Dr. Gruber. Hello, my name is Mao Hu from Acumen, LLC. I'm an Asian American male wearing a dark jacket. I will be speaking about self-controlled studies for fiscal year 2024 safety surveillance activities that Dr. Anderson alluded to earlier. Whoops. Okay. A common approach for assessing outcome risk post-vaccination in retrospective observational studies is the self-controlled study design, where each person serves as their own control. This is in contrast to other designs where the comparator may be an unexposed person or a historical rate. The figure below displays an example of a self-controlled design with post-vaccination risk and control intervals. The risk interval starts after exposure and extends for a pre-specified time period where outcome cases may be associated with the exposure. Cases in the following control interval, however, are not considered associated with the exposure. Persons contribute both risk and control intervals, so the comparison occurs within individuals, giving rise to the name self-controlled. Future safety surveillance studies in fiscal year 2024 will primarily rely on self-controlled study designs to estimate the incidence rate ratios for outcome risk. Self-controlled studies have certain strengths which make them particularly suited for vaccine safety surveillance. First, the self-control comparison offers adjustment for time-fixed confounders such as medical conditions which may impact both likelihood of exposure and risk of outcome occurrence. Additionally, other adjustments are available to address common sources of bias. For example, to address outcome misclassification due to the use of diagnosis code algorithms in administrative claims databases, quantitative bias assessment can be used to adjust the precision of estimates to reflect the positive predictive value of the algorithm assessed via medical record review. To address changing rates of outcomes over time due to seasonal patterns, seasonality adjustments can be made. And last but not least, to address the possibility that death following outcome causes incomplete observation of the control window, an adjustment may be made for event-dependent observation periods. Self-controlled studies are well suited for evaluating rare events in large population-based databases, since both the exposures and the outcomes often meet the assumptions needed to use these methods. They also provide detailed information about effect size and precision, such as confidence intervals, to provide comprehensive assessment of risk. That being said, there are some important limitations to self-controlled studies. For one, misspecification of the risk and control interval can bias estimates of the incidence rate ratio. As with all observational studies, there is a potential for residual confounding. And relative to continuous sequential monitoring, there may be less rapid identification of elevated risk. The self-controlled studies will be implemented in a way which maximizes their strengths and mitigates their weaknesses. First, we will conduct continuous descriptive monitoring of vaccines and outcomes to assess feasibility of the studies on a near real-time basis. Once studies are determined to be feasible, such as by power analysis or by other methodologies, self-controlled analysis will be conducted with a full suite of appropriate adjustments to provide comprehensive and robust assessment of outcome risk. If sufficient outcome cases permit, or if scientific evidence for regulatory purposes is needed, early period analyses may be conducted. Let me go now through some examples of self-controlled studies FDA CBER has conducted that serve as a template for this approach. The first example is a study of Guillain-Barré syndrome after high-dose influenza vaccine in the 2018-2019 season. This study examined the association of high-dose, adjuvanted, and other influenza vaccines and GBS in the 65-plus Medicare fee-for-service population. It used a self-controlled risk interval design where the risk and control intervals are of fixed length. The analysis was conducted in two phases. First, in an early season analysis using a data cut of March 15, 2019, and then later in an end-of-season analysis using data through September 27, 2019. The study found no statistically significant increased risk of GBS, and importantly, findings were consistent between the early and end-of-season analysis, which helps support the utility of conducting early period analyses to generate information more rapidly. The second example I'll go through was mentioned by Dr. Gruber earlier, is an evaluation of 6 outcomes following monovalent mRNA COVID-19 vaccine primary series and third and booster administrations. The outcomes of interest were acute myocardial infarction, pulmonary embolism, immune thrombocytopenia, disseminated intravascular coagulation, Bell's palsy, and myocarditis pericarditis, again in the 65-plus Medicare fee-for-service population. This study uses self-controlled case series design where risk intervals and control intervals may have variable length. And the study found no safety concern for 5 outcomes and inconsistent evidence for pulmonary embolism. With that, I will just end my presentation with some of the upcoming vaccine safety studies which will use a self-controlled design. First, the updated formulation of the influenza vaccine. Second, RSV vaccine in older adults. And third, COVID-19, the updated COVID-19 vaccine. With that, let me turn it over to my esteemed colleague, Dr. Piedluck, to discuss COVID-19 vaccine effectiveness studies in the BEST network.
All right, hi, thank you for the opportunity to present today. I'm Lauren Piedluck, an epidemiologist at Optum Epidemiology. I am a white female standing tall at 5'1", with short brown hair and blue eyes. And in this talk, I will provide an overview of the FDA BEST COVID-19 vaccine effectiveness landscape. These are my disclosures. So overall, the main goal of the FDA BEST VE studies are to evaluate the brand-specific effectiveness of COVID-19 vaccines in preventing two outcomes. So these are COVID-19 diagnosed in any medical setting, and separately, hospital or ED diagnosed COVID-19 among vaccinated and unvaccinated individuals aged less than 65 in the US. The full protocol for these studies is available at the FDA BEST Initiative website or that QR code in the top right corner. So specifically, we carried out 3 separate studies focused on pediatric VE, adult VE, and booster VE. The objective and design of the pediatric and adult VE studies were quite similar, with the exception of the ages included and some secondary analyses. For these studies, our primary goal was to evaluate the effectiveness of receiving a complete primary series of a COVID-19 vaccine compared to being unvaccinated. For the pediatric analyses, the secondary objectives were focused on estimating VE in subgroups and variant eras. And for the adult analyses with a larger sample size, we were also able to evaluate time-specific vaccine effectiveness, the VE of a single dose of a 2-dose primary series, and comparative effectiveness head-to-head comparisons of receiving complete vaccine series of different vaccine brands. And then alternatively, for the booster analysis, the focus was on evaluating the effectiveness of receiving an additional dose or booster compared to not receiving an additional dose or booster among individuals with a complete primary series of a COVID-19 vaccine. And for the secondary objectives, we also evaluated booster VE within subgroups of interest, variant eras, and by homologous or heterologous status, so whether or not someone's booster brand matched that of their primary series. For all of these studies, we used linked data from claims and immunization information systems, which I think you guys have heard a little bit about to this point. But these are population-based databases that store vaccination information and can be used to supplement our capture of vaccine from claims databases. For the VE studies, claims data from Optum and CVS were used, and each data partner separately linked their data to IIS, for which they had legal approval to use that data. And for the VE studies, this included 16 different unique IIS, so they were different between the data partners. And each data partner has more linkages, as you've heard, I think upwards of 30 between the 2 data partners. But the selection of jurisdictions for the VE analysis was determined based on the quality and completeness of each of the IIS linked to claims data sources. So the study design for this analysis was a matched retrospective cohort design. The studies implemented a number of inclusion and exclusion criteria, such as continuous enrollment before time 0 or back to at least when the vaccine was authorized to ensure we were fully capturing vaccinations. In addition, we only included individuals within the catchment area of that linked IIS and claims data for each data partner and excluded individuals who had recent COVID-19 treatment, COVID-19 diagnoses, COVID-19 symptoms, or hospitalizations at time 0. So for booster VE, we also implemented an additional inclusion criteria of individuals having received a complete primary series, so that was 2 doses of Pfizer, 2 doses of Moderna, or a single dose of J&J. For the adult and pediatric analyses, we started the study period on December 11, 2020, when the vaccine was first authorized. The primary series was first authorized, and then booster VE when the booster was authorized on August 12, 2021. So following identification of the eligible populations, we did the following. So we matched 1-to-1 vaccinated and unvaccinated individuals or boosted and unboosted individuals on calendar date and other important characteristics listed on this slide. And for the booster analysis, we additionally matched on the brand of primary series and time since primary series completion. After this,
To control for additional confounding, we estimated stabilized inverse probability of treatment weights from a propensity score model that included all of the matching characteristics as well as pre-specified baseline characteristics. Follow-up then started on the matched calendar date for all individuals, so the vaccinated date of someone in the vaccinated group or the date they were matched for someone in the unvaccinated or unboosted group. And then individuals were followed from time 0, which is the start of follow-up, to the earliest of a COVID diagnosis, separately for each outcome, the end of the study period, disenrollment from the health plan. We also censored them at their deviation from their assigned vaccine exposure pattern. So for people in the adult and pediatric VE analysis, for vaccinated individuals, this meant a receipt of a second dose too early, receipt of a second dose too late, or a receipt of any dose after a second dose. And for unvaccinated individuals, it was receipt of any COVID vaccine dose. And for the booster analysis, we censored both boosted and unboosted groups at receipt of any additional vaccine. And so for analysis, we then used Cox proportional hazards regression to estimate hazard ratios, and then used that hazard ratio to calculate vaccine effectiveness as 1 minus the hazard ratio times 100%. We also conducted quantitative bias analyses to estimate the impact of undercapture of vaccines. Despite the linkage between IIS, we were still concerned that we may not have captured all vaccines, so quantitative bias analysis can estimate the impact of that. And then some subgroup and sensitivity analyses, which I won't have time to present today. So now I will quickly present a few of the publicly available results from the pediatric and booster analyses. I'll note that the pediatric VE preprint is available at that QR code on medRxiv, and that will include results from both Optum and CVS, while the booster VE results, which was presented by poster by Bradley Layton at ICP 2023, will only include results from Optum. So in terms of the pediatric VE analysis, this analysis included over 450,000 matched pairs, and overall the rate of hospital or ED diagnosed COVID-19 was low in both data sources, with rates less than 45 per 100,000 person years. And similar to published studies, we see that vaccination offers less protection against medically diagnosed COVID-19 than hospital or ED diagnosed COVID-19, but it still is effective in preventing both outcomes, with VE estimates of 38% and 61% respectively. VE was similarly high for both medically diagnosed and hospital or ED diagnosed COVID-19 during the pre-Delta and Delta eras. Though it did decrease slightly in the Omicron era, these estimates are imprecise due to limited follow-up. For the booster VE results, which included nearly 118,000 matched pairs for Pfizer, 68,000 matched pairs for the Moderna analysis, and 1,600 for the J&J analysis, we see lower rates of COVID-19 in the boosted groups compared to the unboosted groups. For the Pfizer and Moderna analyses, receipt of a booster decreased the risk of medically diagnosed COVID-19 by more than 50%, and it decreased the risk of hospital or ED diagnosed COVID-19 by about 73% for both brands. And bias analyses, which are shown in the light blue and red circles on that graph, suggest that our VE estimates may be underestimates of the true VE of this booster. We also evaluated VE within subgroups. So between immunocompromised and immunocompetent individuals, we see slightly lower VE in the immunocompromised individuals, but just barely so. However, when we look and compare the Delta era and Omicron variant eras, we, as expected, see slightly lower VE in the Omicron variant era. So in conclusion, I hope this presentation highlights the strength of the FDA BEST initiative and the crazy amount of analyses that have occurred related to VE, and that this is a really robust infrastructure for studying vaccine effectiveness in multiple data partners to generate a big body of evidence. We had a common protocol that was carried out by multiple data partners with a large study population, allowing us to explore primary and secondary analyses, and that these results really do emphasize the effectiveness of COVID-19, especially against severe outcomes like hospital or ED diagnosed COVID-19. So I hope you'll stay tuned for more VE results coming soon. And finally, I have to give a big shout out to the massive team behind this work. It's been my honor to present on behalf of this group, but I do hope we can extend our congratulations to the full team for the body of evidence coming from this project. Thank you.
What a great presentation. Really appreciate all the details and also the links. to preprints and to the articles. I'm just going to remind everyone that you can submit questions through the Slido app. But I'm going to go ahead and take moderator's prerogative and ask to start with Patsy. I think that some of the things that you talked about during your presentation were some of the enhanced capabilities of the BEST system, some of which that were kind of done by necessity, some of were improvements that you made throughout. How is that going to support continued monitoring of the safety and effectiveness of biological products?
Great, that's a great question. And I want to apologize. I did not give a description, so if I can right now,
Please
give
do.
a description of myself. So I am female of Latin descent. I have brown hair and brown eyes, and I'm wearing a black jacket. Okay, in answer to your question, so we had worked with the IIS. We talked a little bit about the IIS and our linkages that our data partners were really involved in, did a lot of the work to get a lot of the various state and local IIS. That work is still ongoing. We know that we are missing a lot of our vaccine exposure data when vaccines are given outside of the traditional setting where claims are capturing, a lot of information for us. So we started with COVID, capturing COVID-19 vaccine data through IIS, but we also have expanded that where we are requesting additional vaccine data from these IIS, so including for mpox and for RSV, we'll be doing that, influenza, so a lot of other vaccines. So it's not just COVID-19. So we do see that continually. We think that will help a lot of the work that we're doing.
Great, wonderful. And Joanne, you talked a little bit about how some of the study results impacted the regulatory thought this past year. How is that going to continue to make regulatory impacts going forward?
Yeah, I think a lot of the studies, when we can provide information as quickly as possible, as accurate as possible, whether we see signals or are evaluating signals, really plays a big role in this regulatory ecosystem. And so when we can contribute data to the VRBPAC, like I mentioned, we didn't see a signal like CDC had. And so I think that's important context because once you try to triangulate information from various sources. And so I think that's really important and has important regulatory impacts. And so I see us doing more studies like Mao had mentioned in the next year that I think will contribute in these spaces and have important implications.
I think that's great. And we heard in the last session about, trying to make sure that you are being able to communicate effectively. And one of those things is, misinformation travels so fast. There's a saying that's not coming quite to my mind about truth not even getting its pants on, while lies are kind of circling the world. And I think that having these kind of systems in place to answer questions really fast is going to make a huge difference. Now, you mentioned some of the innovative new approaches, particularly at self-controlled study, and some of the spaces that you have already used it. What really motivated this change, and where are you excited to be using this in the future?
I think this change is motivated by the need to generate more robust and comprehensive evidence as quickly as possible by merging the signal identification and evaluation process into a single analysis. I think the major advantages of this is that it's going to leverage much more effectively the rapidly updating data sources that the BEST initiative has access to and the increasing integration with IIS that Dr. Lloyd mentioned to paint a very clear, near real-time picture of vaccinations and cases available for analysis. And then second, by applying this very strong self-controlled methodology with extensive adjustment for sources of bias, we can really generate the very best and most accurate evidence for regulatory decision-making, such as what Dr. Gruber described with our inputs into the VRBPAC meetings, et cetera. And this is very valuable for observational studies, which may be strongly impacted by confounding. I hope that answers your question.
No, that was really helpful. Thank you. And Lauren, you talked a lot about kind of some of the new methodologies that y'all had used and some of the the cutting edge methods that you were kind of using in some of these new studies. Can you talk a little bit more about how those have been used and developed to support the vaccine effectiveness work that you're doing?
Sure. So I think our goal here is, and as mentioned earlier, how do we take observational data and make causal inference from it? And I think in my presentation, I focused a lot on how we address confounding. So we individually matched people on really important characteristics. We used stabilized inverse probability of treatment weights to address residual confounding. We used quantitative bias analysis to estimate the impact of remaining under capture of COVID-19 vaccines. And I think that some of the sensitivity and subgroup analyses that we conducted, in addition to what I had time to present today, also get into some of that, one of which I will mention today, which is, we talk about confounding bias, we've talked about misclassification of vaccines, but what we haven't talked about is selection bias. And in vaccine effectiveness studies, the main concern with selection bias is that in a Cox proportional hazards regression model, you assume that when individuals are censored, those who are censored are basically a random sample of the remaining people under follow-up, which in vaccine effectiveness is a heavy assumption, because when you're matching unvaccinated people to vaccinated people, and some of those unvaccinated people get vaccinated, they're probably not just like the people who remain under follow-up and are unvaccinated. So as part of our sensitivity analyses, we do explore inverse probability of censoring weights. We explore altering the window at which we censor, so whether we censor on the date someone receives a vaccine or 7 days after, in order to account for the fact that at that moment the vaccine does not immediately become effective. So there's just a wealth of methods, and I'm really excited for this research to get out into the world so that people can see how we really took the bits and pieces of the growing body of evidence in causal inference and applied it to study vaccine effectiveness.
Great. We do have a couple of questions coming in from the audience, and we do have just enough time to ask a couple. Please feel free to keep sending those in. One of them is directed at Patsy, but love to have everybody else jump in too. One of the things that you said in your presentation was that the criteria for inclusion in BEST is the ability to have easy, affordable, and timely access to medical charts. I will say that phrase makes me think better, cheaper, faster. You're only supposed to pick two. Can you tell me a little bit about kind of what do you mean by those criteria, and how we can move towards that state so that more people can be included?
Sure, and I'll start, but please, others can chime in. Yeah, I think what we're trying to get at is, and what we need are, if we do need to ensure that what we're seeing in the claims data are accurate, that the outcomes that we're looking at, they truly are the outcomes that they say they are, we need to be able to verify that. And so that requires pulling some of the charts, making sure that there was not misclassification, for instance, or there was that individual may not have experienced that before. Being able to, again, pull those charts quickly is going to be really important for us. But again, please, others, if you want to chime in, I think that's really,
All right.
Yeah.
Okay. Thank you.
Covered it. Thanks, Nancy.
We also have a question around the mother-baby link data. And this person asks, why do you think the link percentage is so low in mothers, under 25%? Do you think that in the future, FDA will start executing pregnancy database studies as opposed to issuing these as PMRs? Does anybody want to jump in on that question?
I can take a stab at it if you
Please.
want. So I think the percentage of the linkage percentage is more around 70 to 80%.
Oh, wonderful.
It was under 25 years of age.
Yeah, okay. So is
Oh,
that
I'm
what
sorry.
Sorry,
I
okay.
misunderstood the question.
Okay.
For under 25-year-olds.
Yes,
Thank
yes.
you.
We think that the younger age groups might not link as well because of insurance-related issues, because we're, again, subject to who's in our claims databases and then looking in our claims for the infant. And so we're thinking if there's some, this includes commercial claims, and so if we're missing, if younger mothers are less likely to be commercially insured, or if they're really younger, they might be on like their parents' plan still, and so that we're having a harder time finding those infants is I think the reason that you see those lower percentages in the younger age groups. But we're hopefully going to continue to build our capacity to get more comprehensive, linkages across all age spectrums.
And that makes sense with the limit being 26 to stay on your parents' insurance. So if the dip is at 25.
Yeah.
All right. And then can we talk a little bit more about the rationale and impact of the rapid cycle analysis? And it says, for example, RCA has been used by government agencies to screen relatively large risks following vaccination. Is there any concern of delaying safety signal identification?
I think the Best Initiative Data Network has really developed an infrastructure that's so strong and so comprehensive with regards to integration of immunization information systems data, use of very rapidly updating, low data delay databases, that it really enables these much more stronger analyses, and I think it really mitigates some of the very real and certainly potential concerns with lack of identification of signals on a rapid basis.
All right. Well, thank you all so much. This has been a fabulous panel. I really appreciate it. Can everyone thank our panelists? All right. And I'm now going to be turning it over to my colleague, Rachel Hendricks-Stirrup, who is going to be moderating the next session around linked claims and EHR data.
We're just getting Rachel mic'd up. There's a mic handoff. She'll be there in just a moment.
Well, all right. Thank you for your patience. I couldn't get a mic until the others were finished, so thank you again. Really happy that we've heard from the BEST group. Now we're going to turn it to to the Sentinel Innovations Center's efforts to improve causal inference and broaden queries using EHR and claims data linkage. As a reminder, the Sentinel Innovations Center is part of the Sentinel System, and the title of this next session is Linked Claims EHR Data, focusing on Sentinel Systems' effort at improving causal inference and broadening queries. I realized in my earlier panel I forgot to provide a description of myself for our listeners. I am a 5'4" female of medium complexion and dark brown eyes and long hair. That doesn't sound like a law enforcement description of me at all, does it? Anyway, I'm really happy to welcome our next set of panelists for this session. We have Sebastian Schneeweiss, who is a professor of medicine and epidemiology at Harvard Medical School and chief of the Division of Pharmacoepidemiology within the Department of Medicine at Brigham and Women's Hospital. We have Jennifer Nelson, who's the director of biostatistics and a senior investigator at Kaiser Permanente and Washington Health Research Institute. We have Richard Weiss, who's an assistant professor of medicine at Harvard Medical School and the lead investigator in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital. Lastly, we're joined by Bob Ball, who's the deputy director in the Office of Surveillance and Epidemiology at the Center for Drug Evaluation and Research, or CDER, at FDA. So Sebastian, Jen, and Richard will start us off with a presentation. Afterwards, Bob will provide reacting remarks, and then we will have a brief discussion or Q&A session. As a reminder, we encourage everyone to, both in person and online, to use Slido to submit their questions. And that being said, I'm going to turn it to Sebastian, who will kick us off.
Great. Thank you very much, Rachel, and thank you very much for having me here. I'm Sebastian Schneeweiss. I guess I look like somebody who grows up in Munich, Bavaria, and Central Europe, and I am too tall to be a jet fighter pilot and not tall enough to be a wildly successful basketball player. These two top career choices not panning out. I became an academic, put a gray suit on, and here I am. So the Sentinel Innovations Center, this was teed up already by Dr. Delpan, by Dr. Toe, and by Dr. Seeger to some extent. The key objective of multiple activities in the Innovation Center is to fill the gaps that are left by the claims-based, widely successful activities of the current Sentinel system and expand that, expand the area opportunities. And when you want to expand the key insufficiencies, you quickly think about their data insufficiencies. Most of the insufficiencies are data insufficiencies. I think we do very well today in understanding causal study designs and causal analytics. We very much will focus on data, and we have seen this also in the last panel. So what we have done over the last 3.5, 4 years, we have built the following infrastructure where we work with Health Verity and Trinetics, our commercial partners, where we have identified about 20 million lives, where we start out with the EHR data and link the claims data to each of those patients. And we require a certain overlap in person time between those two data sources. So they're not totally disjunct in time. There's some overlap that we require in order to really have both of those data types available, which we describe as the best of both worlds, where you have the continuity of capturing all encounters with the healthcare system while you're insured from insurance claims data, and you have the deep dive clinical characteristics coming from the EHR system. And in a fractionated healthcare system like the United States, you will need both in order to know where your gaps are. On the right side, you see the development network, which is based on the 4 centers that make up the Innovations Center, that is at Kaiser Washington, at Duke, Vanderbilt, and the Brigham, where we have direct access to the EHR, including the free text notes. What this sums up to about 3 million. The Innovation Center sits in the middle of that, where we develop algorithms, where we set up queries that we are going to ask. We receive the structured information from these 20 million live from Health Verity and Trinetics. The free text information remains behind the firewall. In the development network, as I mentioned already, we do have access to the free text notes, which we use then in order to develop algorithms that go back to the free text notes. We test these algorithms, we test the transportability of the algorithms between the sites, the 4 sites, and then use the algorithms in the commercial network. This is done in close collaboration with the Operations Center with regard to quality control. The data are put into the Sentinel Common Data Model, and we have identified a bunch of key use cases. I'm going to talk about that. This is kind of the roadmap. I'm not going to talk about this at length, just showing that there are many building blocks that brought us to the point where we are now, where we can have a system in place, where we put the system to an intensive test. So let's talk about the value add of this data infrastructure that we have now, where we have EHR and claims data linked together with some overlap in person time. We can reduce the insufficiencies, particularly when we can do the entire study in this asset of about 20 million lives. 20 million lives sounds a lot for some people. Doesn't sound a lot for other people who have done these types of studies, because you start out with 20 million lives, then you're focused on one indication, let's say diabetes, which is a fairly frequent condition. You focus on a frequently used medication, let's say SGLT2 inhibitors, canagliflozin or some other gliflozin. You look at a frequently occurring endpoint like a genital infection, relatively frequently. Then you come up with estimated 260 events, right? And that is, you can do some studies with this number of events. Once you study rarer events, it's getting dicey. When you look at diabetic ketoacidosis, we estimate 10 events. And when you then study subsets of these populations or rarer conditions, the numbers of events are getting very small very quickly. And so some studies we can do entirely in this asset. For other studies, we need to wait until the 20 million grow to maybe 100 million. It is the 100 million bar that was set for the Sentinel main system. But we can also do a lot of other use cases in subsets. So there's a power calculation here. The beauty, of course, is that, or let's put it that way. Sometimes I make this sound too good to be true, the EHR and claims data. Everybody who's ever worked with EHR data this is just a can of worms. Once you open that, there's just problems lurking around every corner. And it's still data generated by the routine operation of the healthcare system. So the information, even if the information is available, it might not be captured at the right point in time. There's all sorts of complications. So there's a lot of methods work in order to harness the information that is available in the EHR data, but not as prepared as you would like them to be for causal study design. Now, there's a whole bunch of value add if you treat these 20 million lives as a subset of the larger 100+ million lives claims data asset that the Sentinel has available in its querying. And there's a bunch of use cases, and I want to briefly walk through these. We identified 5 high-priority use cases in order to reduce the proportion of area insufficiently deemed research questions. So use case number 1 is rapid confounder balance evaluation. So we use balancing techniques, as we had heard in the last panel already, based on claims data only. We achieve a balance that we can demonstrate in claims data, let's say propensity score matching, for example. And then you have a subset of patients where you have electronic health records available where you can dive deeper. You have information that you don't have available in claims data, and you can check whether the balance that you have achieved by matching on claims only also resulted in balance in the unobserved characteristics that you don't have in your main study available. So that's fairly easily doable. There's an example here in 2 antidiabetic medications. These are all a bunch of lab tests here. You could imagine this being BMI information, other information that is not available in claims but available in EHR, the duration of diabetes and other parameters that are frequently quoted as making studies ARIA insufficient. So that is a reassuring analysis. Well, the problem is, of course, if you do see imbalances in these characteristics, you need to do something about it, and there are techniques, statistical techniques, to correct your main analysis and claims data based on what you find in your subset. The imbalance that you find, you can back calibrate or do other imputation strategies, and Jen Nelson's going to talk more about our experiences in that space. A third use case is something that was already mentioned in the previous panel as well, is expedited validation of claims codes. This is just way too inefficient. If a study like that takes about a year to complete, we have to do this in a couple of months in order to identify the measurement characteristics of claims outcomes, of key confounders, of population identifiers. So we have developed, Vanderbilt has developed a tool for very efficient electronic health record validation where you type in kind of the initial search terms and this will be highlighted then in the free text notes, which is often a mess, particularly with these chronically ill patients with pages and pages of free text notes. The machine learns with the reviewer, and the machine is suggesting similar terms that are observed in the proximity, and is helping the reviewer in this feedback loop to be faster in finding the relevant sections in the notes that might be completely new to the reviewer. There's another trick that we are going to apply, which is kind of providing batches of records to the expert reviewer and focus on those batches where there's the most uncertainty. Records where it's fairly clear that they are a case or very clear that they're not a case, we don't need many of them re-reviewed. We need more the middle section where there is the uncertainty. So there is efficiency in several spots that we are using in order to make the whole process way more efficient. Another key use case, of course, is NLP to extract phenotypes out of the free text notes. And we have a pipeline developed here, largely at Kaiser Washington, where we start out with dictionaries in order to find key terms. We then fit this into the pipeline where we develop silver standards in order to pre-feed information to the gold standard review, which is the costly and time-consuming part of this whole thing. Everything else can be done by the machinery, and we think that the large language models can be very helpful on the left side of this whole chart before we go to the expert review in order to develop the reference standard, and then this data that is derived from that, this is derived information, will then be amended to the central common data model. We had another work group work order on that. The last use case that I want to touch on before I hand over is the signal detection activity, where the tree scan methodology is quite developed and accepted in claims data, very structured information. We have a hierarchical coding tree, ICD-9-10. In free text notes, things are much more messier and not hierarchical. And so we have one activity that is kind of a data extraction activity that is pre-preparing the information. And MEDRA is one of the standards that we are mapping the data to. And then we have in the process of developing an expanded tree scan activity that is going beyond claims data, but is going to using this MEDRA information that is not hierarchical, that is dealing with not binary information, which claims data often is, also continuous information, and make the whole algorithm much more flexible. But the principle of tree scan is preserved. It's an expansion of tree scan with which the FDA has quite some experience and comfort. So we're just building on that in order to make it available to these new data assets that we have been built and will be expanding. Year 5, that is beginning as we speak, is all about emulating ARIA-like queries and see how much can we expand the territory of ARIA sufficiency. The questions that have previously been deemed insufficient can be turned sufficient because now we have access to the EHR data and through these 5 use cases that I demonstrated. I think with that, I hand over to Richie Weiss first.
To move the microphone down after Seb. I'm a white male, brown hair. Is that good? More detail. So here I'll just very briefly be giving a background on one of the projects that we've been working on in the Sentinel Innovations Center. And really just kind of a topic that we're really interested in general with the Innovation Center, which is how can we improve confounding control when we're analyzing these very large healthcare databases involving healthcare claims linked with electronic health records. And so the reason why we're so interested in covariate adjustment in pharmacoepidemiology is it's really foundational to everything we do. Whenever we're trying to estimate the effects of treatments on outcomes to establish causality, it requires some form of covariate adjustment to adjust for the different biases, really confounding being the big challenge or the big bias that we're mostly concerned about in these settings. And so, you know, the issue of confounding, the real challenge with confounding in these healthcare database studies is that a lot of the information that we would like to adjust for, or covariates that we would like to adjust for in our studies are just not directly measured in these healthcare databases. And so this is a challenge that's really been discussed now for well over a decade now in the pharmacoepidemiology literature, where a lot of researchers are arguing that we really should think of these databases as rather indirectly capturing information on a lot of the variables that we want to adjust for, rather than directly capturing information on variables that we want to adjust for, like frailty, health-seeking behavior. And researchers have argued that if we adjust for very large numbers of codes, though, or constellations of codes that might be indirectly associated with, you know, features that might not be directly measured, we can at least in part adjust away for some of the confounding impact of variables that might not be directly measured in these settings. And so this is the idea of proxy confounder adjustment, or high-dimensional proxy confounder adjustment in healthcare database studies. And so this idea of controlling for very large numbers of variables has really gained a lot of traction and become very influential in the pharmacoepidemiology literature over the past decade or so. There's a lot of different groups really independent from each other that now kind of advocate for this type of approach to approach covariate adjustment in these healthcare database studies to try to mitigate bias. But a big limitation of all these approaches is they don't leverage the full information content that's available in electronic health records. They really require data to be in a structured format. And so in particular, free text notes in EHR, which potentially contain rich information not captured by claims data alone, are just not utilized for this type of covariate adjustment. So this is what we were interested in this project and with the Sentinel Innovations Center, is can we leverage the unstructured information in EHR at a very large scale to potentially improve covariate adjustment and confounding control in healthcare database studies. And so in doing this, we collaborated with another research group at Brigham and Women's Hospital, Josh Lin and a group of researchers in bioinformatics who received some NIH funding to look at ways of applying natural language processing to free text notes with the goal to just generate large structured data Here, the application of natural language processing is very different from how we typically apply natural language processing to EHR, where usually when we're using natural language processing, it's for clinical phenotyping or to identify specific clinical features to improve, for example, outcome assessment, which I think Jen might be talking a little bit more about in her slides. But here, the objectives with Josh's team was very different. It was just simply, can we apply NLP in a very large, scalable way to just generate structured, ordered data, which could then be used, further down the analytic pipeline for covariate adjustment and improved confounding control. And what we were interested in this project is once we have this data, we have this high-dimensional structured EHR data, and we then link it to other high-dimensional claims data, which is now what some people call ultra-high-dimensional data. How can we best analyze this data? Is there any additional confounder information that we can extract from this to supplement investigator-specified variables? So this is just an example of the type of data structure that we're talking about, with a few dozen predefined investigator-specified variables and then thousands of additional proxy variables coming from claims codes and EHR features. And so typically when we analyze high-dimensional data, analyzing high-dimensional data is not new to pharmacoepidemiology, and typically the go-to tool is lasso regression. There's now been several studies that have been published in the epi and biostats literature with different groups comparing different machine learning tools for large-scale covariate adjustment. And the results are pretty consistently showing that it's just very hard to beat a lasso regression model. But when we were applying a lasso to these data structures, where we started to add much more additional noise from these EHR features, we were finding that the performance of the lasso model was degrading pretty rapidly as the amount of noise in the data was increasing. And so we weren't really sure how best to move forward when we found some publications by Mark Vanderland and his team at UC Berkeley. This is a group of biostatisticians who also work a lot in this space of large-scale covariate adjustment, where they showed that in theory we really want to be overfitting these lasso models, which was different than what we're typically doing in practice. But how much to overfit these models, we're not sure about. If we overfit too much, then we run into positivity violations and harm the properties of our effect estimates. But if we don't overfit enough, then we're excluding important confounder information. And so this is the project that we worked on. We reached out to Mark and collaborated with his team to explore over the past year and a half of looking at dozens and dozens of different simulations and trying different ways of fitting these lasso models to see if there's an optimal approach that we can figure out how to overfit these models to optimize confounding control when analyzing these data structures. I won't go into the details of the different models that we fit, but just some general findings or conclusions and patterns that we found is that consistent with their theory, which always doesn't translate to practice for anybody who tries to implement these methods. Often, theory shows one thing, but then when we try to implement them in, settings where assumptions aren't satisfied, we get different results. But consistent with their theory this time, we actually found that we did see quite a bit of reduction in bias when we overfit these models. But it came at a cost of we also increased the variability of our treatment effect estimate. And so work that's currently going on now is, we think this is really exciting that we've found methods now that we can start to improve bias reduction when we're analyzing these ultra high dimensional data structures, but there's still limitations. We're still trying to figure out how we can best overfit these models so that we don't increase the variability in our effect estimates too much, and this is ongoing research that we think is really exciting. Something else that came out of this project is that it does look like it's possible to fit these NLP tools in a scalable way to generate these high-dimensional data structures from EHR data. And so there's a lot more work to be done, but we think this early work is pretty exciting. And I'll stop there.
Thanks, Richie. My name is Jen Nelson. Very happy to be here today. Thank you for the opportunity. I'm a white female with brown hair. My husband claims that I'm short. I would like to posit that I'm strongly medium. I'm wearing a gray jacket and a pink blouse. So I will dive into some more detail on the second and the last use cases that Sebastian introduced. The second case involves correcting for claims analysis when there's unmeasured confounding using subset information and calibration tools. So as Sebastian noted, one of the key challenges for ARIA and sufficiency is incomplete confounder capture in the claims data, which can lead to bias when we adjust for perhaps mismeasured or not all the confounders that we need. One example that I've seen in my research over many years is confounding by healthy user bias or frailty when it comes to vaccine effectiveness estimation, for example. A promising solution to this problem, and one we've seen outside of Sentinel and we want to bring into use within Sentinel, involves measuring more detailed information on a subset and then calibrating to reduce bias in the estimates that we get from the claims data. And so we've initiated a project earlier this year to further explore this. And this is going to build on a lot of methods work that has already happened within Sentinel. There's been work to better understand the data, and in particular the newer EHR data sources that are linked up to understand why we're missing data for certain people. We'll build on that work by studying a broader range of calibration methods. Many of the methods have been assessed already that are commonly used in practice, including a complete case analysis, inverse weighting, multiple imputation. And what we're going to explore this year are sort of more newer and potentially more robust and precise methods, which are important when we're looking at safety when we have rare events, including survey calibration, targeted learning, and other approaches. And our focus is going to be to start, as Richie was describing in his use case, in simulated settings so that we can compare these methods with known conditions. And overall, I think what's really exciting about these types of approaches is that we get to both exploit the rich EHR data to reduce bias, but we continue to get to leverage the power of the large claims data sources and the large sample sizes that those provide. Okay. The last use case that Sebastian mentioned involves expanding claims data analysis and with a particular eye towards deep clinical information to better inform our outcome definitions, confounders, and potentially inclusion criteria. So the projects I'm going to describe here focus on the outcome aspect of that problem. And so another key challenge for ARIA is that some outcomes are inaccurately captured with claims. And again, this can then lead to various magnitudes of bias in analyses of effect estimates. Some examples that FDA brought to us earlier years ago to begin to study include anaphylaxis, as well as acute pancreatitis, among others. Again, a solution here is to link to EHR data. And in this time, what we're doing is we're extracting, like Richie described, structured features from unstructured clinical text in the EHR. And our goal here is to really, instead of using ICD-9 codes to define outcomes, we want to build better models, build better algorithms that can take advantage of structured features that we can grab from unstructured clinical notes and use robust modeling techniques to then come up with more accurate algorithms that FDA can use. We want to do this in a way that's relatively simple, as automated as we can, and create tools that can be reusable. We've had a suite of projects over the first 4 years in Sentinel that will continue into year 5. So a lot of this work is completed, but continuing on, it's been a strong focus of the Innovation Center in the first several years. And we refer to this work as computable phenotyping. So what I'm showing in the upper right-hand slide there is the NLP pipeline that Sebastian introduced earlier in his talk that show the steps. So the projects that we've conducted include 6 different pieces of work. We've done 2 validation studies where we have done chart review to get gold standard information to understand the true status of whether someone has anaphylaxis, for example, or acute pancreatitis, and compared those to the common ICD-9 code definitions to confirm that indeed those outcomes are insufficient when it comes to, or not as good as we would like if we're going to use those claims definitions. We've followed on with 2 studies where we've done NLP extraction of information from clinical text, also getting information, other kinds of information from EHRs like lab results. That's a particular helpful aspect to look at when it comes to acute pancreatitis, for instance. So we've done model development studies to increase the claims-based positive predictive values when it comes to those algorithms with great success. We had an additional NLP-focused study focused on a different aspect of accuracy, in particular trying to find missed cases to improve the sensitivity of those outcomes. And all of this, sort of our ultimate goal here is to provide a framework that gives best practices for taking these steps towards making computable phenotypes. And so the deliverable there is, we really want to facilitate effective and scalable use of this methodology that Sentinel can take going forward for the future. Those steps involve, it starts with deciding for a given outcome, is it a good idea to attempt computable phenotyping for this outcome? And if so, follows through with, okay, well, let's compute some gold standard data so we can evaluate the algorithm in the end. Let's do feature engineering, model development, and model evaluation. And so our group has worked to develop steps for being able to do that going forward within Sentinel. And so this is just a simple picture that describes that first step that I was talking about. We first want to understand, is the bang going to be worth the buck for a given outcome? And what goes into making that decision? And we would propose that you need to look at, what's the level of clinical complexity of the outcome that you're examining? Do physicians tend to agree when they're making a diagnosis? And things like that. And the more complex, the more difficult it may be to be able to find an algorithm that works when it comes to scalable phenotyping. Similarly, but different, is the data complexity. How do the data tend to appear for a particular outcome in the notes that get written? That's subtly different, but different from the disease itself being complex. And so this just shows that as either of those two aspects increase in complexity, the probability of success that you'll be able to successfully do a computable phenotype that improves accuracy likely is to go down. And so you see anaphylaxis in the top right here. We actually had reasonable success there, but I think the lower lying fruit, and we're trying to help FDA prioritize where to begin in terms of which outcomes do we want to point towards these processes, will be on the bottom left-hand side of this graph. All right, and we're going to continue this work on in year 5. Thanks very much.
All right, thank you to our presenters. Thank you, Sebastian, Jen, and Richard. And next, before we move into our Q&A or our broad discussion, we're going to hear reactant remarks from Bob, who will provide an FDA perspective.
Thank you, and glad to be here to talk about all the great work that's been going on in the Innovation Center for the last 4 years. And as some of the earlier speakers mentioned today, we started off 4 years ago with a strategic plan. So at the time, we kind of knew what the problem was. We knew that there was these issues, especially around the data. And we outlined what we thought were the general areas where work needed to be done. And you saw in Sebastian's slide that he didn't really talk about all the projects that were done in those areas that have taken us to this point. So there's an enormous amount of work that's gone into this, and so congratulations to Sebastian and everyone in the Innovation Center. Probably the key issues remain the issues around the data. And so I think I'm very excited to see the linked claims-EHR systems coming together in a practical way. And in this 5th year, as Sebastian outlined, there's going to be a couple of projects where we'll test the ability of those linked claims-EHR systems to address some of the problems that we found in the ARIA, the Active Risk Identification and Analysis System. And I think equally important are the general frameworks. The first one on the causal inference, the principled framework that was mentioned this morning. The framework that Jen just mentioned around how to decide when a computable phenotype might be worth attempting. Some of the other efforts to improve the efficiency of chart review. So that's the essential aspects of making these efforts scalable and sustainable. Because it's one thing to do a one-off project, but when we have dozens of analyses we have to do, they have to be scalable and sustainable. So you start to see how some of that's coming together here. And then, Richie's and Jen's presentations, I think, are also looking forward to some of the continued technical challenges and scientific challenges in analysis of this complex data. And I'm very excited to see the introduction, or even perhaps more than introduction, but the use of these machine learning methods in the analysis phase to improve our ability to do causal inference. So overall, I'm really looking forward to this 5th year set of projects, the lessons learned from that, and then incorporating that into the future of the Sentinel system. So thank you.
Thank you very much. All right. Thank you all again. Thank you, Bob, for your remarks. We're going to move into our brief moderated discussion now. As a reminder, both our in-person and virtual attendees can submit questions through our Slido function, which we have enabled for all of you to access. And we do have a few questions prepared to kick off our discussion, although we'll certainly attempt to incorporate questions from the audience during this time as well. So we've got about a little more than 10 minutes or so to kick off our discussion. So my first question is, and many of you have touched on this already, particularly as it concerns EHR data and linking that data to claims data. We talked about some challenges in doing that, some of which are certainly inherent to EHR data itself, given that it's literally a data source of a data source that is conveying outcomes that are, or at least data that has been collected in a non-randomized fashion. A lot of proxy factors to consider across one or more EHR systems at a given time. So what remain as other challenges, or perhaps greater or even lesser in terms of priority challenges to linking EHR system data to claims data? Thinking about successfully, what can that look like, and what are challenges to get there?
I think we are still in the process of learning what we can do and when these data are performing well. So in oncology, for example, we have quite some experience where these data and the data collection mechanism with electronic health records works quite well because it's a very cadenced encounter system, while in for other conditions, the data collection is much more sporadic. And getting a sense for what type of studies will be doing well in these linked EHR claims data asset and what are the studies that will still be difficult will be an important experience to guide the use of this asset.
Mm. Thank you. Any additional thoughts from the group?
Yeah, I would just, I think, extend the comments. Many of the safety outcomes are rare and sort of atypical conditions. And so sometimes also, even thinking about efficacy studies for rare diseases in particular, the outcomes will be rare by definition, but also just require data elements that aren't typically available in standard EHR systems. And so while we could say, well, all you need to do is link to the systems that have those data, that of course would mean we would have a massive system which is very hard to sustain. So I think we have to be thinking about how we do creatively what I think of as just-in-time linkages. So I have a study, and now I have to go claims. I have to find that data I can link, and then rapidly do the study I need.
Yeah, I think one other thing that's really useful about the implicit structure of how the Innovation Center has been set up is that we have the 4 lead sites, and several have claims and EHR, and so you can kind of explore problems. You've got EHR data in your hands already, and you can see where you have challenges. You can walk down the hall, talk to the clinician who might have filled out that chart, and understand and see where this type of problem might exist elsewhere, and this is something to be aware of. So it's a nice test environment.
Very nice.
And I'll just add a big challenge, something that we think a lot about when we're trying to use these linked EHR claims data for purposes of causal inference is, once we have the data linked, early on we were really excited thinking that EHR was going to solve a lot of our problems, but then we started to realize it causes a lot of maybe more problems than they solve. And one of the biggest problems that we always see is that there's this differential capture of information with the EHR data. You don't have this continuity of follow-up. So even if we have this linked data, a big challenge is trying to find subgroups within that linked data, which further reduces our sample size, where we can be relatively confident that we're doing a good job of capturing the information in the data, so that we don't have this differential surveillance between the treatment groups that we're trying to compare. And so that's a big challenge, that even if we have this additional information that we're getting from EHR, sometimes it can often reduce our sample size for these causal analyses for that reason.
Yeah, thank you all for your points there. And actually, I guess even to that point, we have a question for Sebastian, but certainly for anyone that would like to answer this question. Considering electronic health record data being collected in a non-randomized, non-systematic way, what advancements have been made in underlying data sources like EHRs? We can even use that as a prime example here to improve causal inference. What are your thoughts?
So if you just take the data system as it is, and of course there's huge variability, you have the highly integrated care system like the Kaisers and the Geisingers of this world, the issues are totally different from what we otherwise see in a very fragmented healthcare system, where you're never quite sure how many of the encounters you're capturing in your EHR system. And this is going along the line what Richie just mentioned. And even if you know that you're missing encounters because you see the encounters in the claims data, but you don't have the underlying EHR data, right? What does it tell you, the fact that you don't see that information? What does it tell you that the fact, even if you see the encounter in EHR, that certain tests were not performed? Most likely that is highly informative. And are there some, and there's a researcher at UPenn, she's Rebecca Hubbard, doing great work in differentiating between visits that are more kind of informed by the underlying health state, and other visits that are more kind of routine visits, right? And to disentangle the biasness of the information, or the correlation of information with the outcome of interest, and therefore biasing causal inferences. So there's a whole bunch of questions that can be addressed and are in the process of being addressed in order to make more use of these data. Because we need these data, we need the clinical detail. Right? And there's no perfect world. If you think about this highly integrated system, like also in the UK, the NHS system is these primary care focused systems. In that universe of the primary care, you have much more complete information, right? And there's a whole bunch of things that you can do that is much more difficult to do in the US system because of the fragmentation.
Indeed. All right. Unless anyone has anything else to add, we have a few questions from our audience, actually. One question centers on NLP algorithms, or natural language processing algorithms, NLP used for short to describe that. Will the Innovation Center publish the performance of their NLP algorithms, and also how do you expect these algorithms to be transportable across EHR systems?
Very good questions. So I mentioned two modeling studies that we've conducted. I think one, the anaphylaxis, that is published, and so that can be made available. That is available. The second paper is in revision, so those will be out shortly. And it really is the tip of the iceberg in learning about how we do scalable phenotyping, but it's showing, I think, good promise. So that will be available. And the second part of that question?
How do you expect these algorithms to be transportable across EHR systems?
Yeah, we've had a lot of interesting conversations about that. As a statistician who's worked for 20 years in the realm of vaccine safety and now drug safety, I think one of the most important things is to be looking at site heterogeneity. Mm-hmm. We can learn a lot from what is not the same at different sites. And so there's actually work in a number of directions on that topic. There's one project that's been ongoing within Sentinel that we didn't talk about today that has to do with harmonization of data sources led by Sue Shi and her team at Michigan. And this is about automated ways to use natural language process analogous algorithms. So looking at a code and its nearby neighbors, things that tend to occur with those codes, like what you do in NLP to kind of get context around a word to understand meaning, and to try to learn when one coding system at one site is not the coding of that is not quite the same at another site. And so the idea behind that is before we even input something into an NLP algorithm or any model or a causal inference model, we align the data first. So this is kind of bigger picture, long-term visioning, but the idea would be to align the data elements, the how we defined the confounder, the outcome, and the exposure before we plop them into a model, and then So the other end of the spectrum is if we don't do that, which is what we don't do right now, we get models that are developed at one site that may or may not transport to other sites. In the work that we've done so far, we have actually seen better than expected transportability. There have been models for COVID-19 developed at, I'm not sure which way, I think this publication is also in press, either developed at Kaiser Washington and applied at Vanderbilt or vice versa. And they actually worked surprisingly well, and those systems are not at all alike. That said, we can't be guaranteed. Most of the time that may not be the case. COVID is very unique, and so there's a lot of statistical ways we can think about transporting algorithms, updating, and it's not just heterogeneity across sites, it's heterogeneity over time. The algorithms are not necessarily going to work today and tomorrow necessarily as these data change. So it's a great opportunity, I think, for us.
Which is also why the structure of having this development network is so important, where we can test the transportability within the sites where we have central investigators sitting firsthand on the free text nodes.
Mm-hmm. Well, thank you. I think we have a little more than 1 minute probably for one last question. What do you see as the future impact of this work? How has it already made an impact? And are there any challenges to address? I know we've talked about a lot today, but as we close out, what are your thoughts?
Certainly we also want to hear from Bob on that, but certainly, I mean, the whole thing was designed from scratch with reducing the area insufficiencies, the proportion of questions that are deemed area insufficient. And if we're successful, that proportion will be going down, and we're working very hard in achieving exactly that through these multiple approaches based on expanding the data source and the different methodological approaches to make good use of them.
Yeah, so I think the single biggest impact is to realize that there are systematic approaches that can be applied to solve these problems. And you heard earlier from Gerald Delpan that we're waiting a year before we do our next RFP. And one of the reasons we're doing that is because we want to learn from this next year's experience about how these general frameworks and these specific approaches actually work. And there's another project that we also didn't discuss for this year, where we're going to apply the general framework to some of the outcomes that were insufficient. And that'll give us some direct knowledge to say, is it 10% of these insufficiencies that are going to be solved by this problem? Is it 90%? Is it 50%? And that'll really help us, I think, understand what the implications are for the work.
Excellent. Well, thank you all so much. That wraps up this panel. We want to thank you all for joining us once more. Thank you all for listening in.
Thank you, Rachel.